In terms of disclosures, I don't have any financial arrangements related to the content of this activity. Today, we're talking about how to help patients make positive change. We'll be doing that by discussing just the absolute basics of motivational interviewing, as well as the complementary transtheoretical model of change. And I do want to say a quick thanks to Doctors Bott, Fernandez, and Lindsay, as I have borrowed several of their slides to adapt here. Our objectives today are to discuss the key characteristics of each stage in the transtheoretical model of change, although we'll do it very briefly. We'll review the introductory principles of motivational interviewing as they relate to substance use and other health change behaviors. And we're going to try to identify accessible strategies that can be applied across settings to support patients in making those health promoting changes. So we won't dive into techniques. That's a bigger topic than today, but we'll look at how the philosophy can be applied sort of moment to moment with the big strokes with patients when we're trying to help them make change. I know it sounds weird to put the takeaways at the beginning, but in looking at how we've done this presentation over time, there's just so much to cover, and I thought this would help us kind of focus. This is what I'm hoping we'll really hit the highlights on by the end of the presentation. The first is the importance of matching the stage of change. So making sure that the patient is getting the intervention that's really going to be useful to them based on where they're at. Then highlighting successes. This is something that people really underestimate the power of. Making sure that we're really reinforcing every small incremental step towards positive change really helps patients to pick up momentum when they might be stuck in that more ambivalent mode. And that goes along with encouraging autonomy. So making sure that patients understand that they're the one that's the captain of the ship, and that we really understand what's most important to them about making these changes. The last one I think sounds easy, actually in reality is quite a lot harder, and that's in having these conversations that we use our ears more than our mouths so that we resist that very human impulse to try to talk people into doing what we see as the best option for them, and instead invite them to share about why they think it would be an important change because the research very firmly supports with motivational interviewing that when we listen better, then we can do a better job of rolling out the red carpet for change, so to speak, even though that's counterintuitive. So we'll start with the trans-theoretical stages of change model. This is an evidence-based model that helps us to match where a patient is at with what they need in order to benefit from treatment. So it's not an intervention in itself, it's really more like a brief assessment that helps us to calibrate our approach to make sure that we're meeting them where they're at. People often talk about the stages to change model and motivational interviewing in the same breath. They are separate things, same body of research, same era, but two totally independent constructs. It's just that the stages of change model is really, really helpful for helping us to figure out when motivational interviewing is going to be helpful because it's actually only within one specific stage of the model that it has good evidence, and it can actually be counterproductive in other stages. So you can see why they go together so well. So this is one way to graphically represent the stages of change model. I do want to make a couple notes on the developer's behalf about how difficult it is to actually graphically represent this. So they always want us to emphasize, this is neither a flat nor a linear model. This is just the easiest way to conceptualize and to teach it. You'll notice each stage is matched to an interlocking arrow. But this is not a case where it always proceeds in this very orderly fashion. It's very common for patients to kind of jump in and out of different stages that are not necessarily adjacent here. That doesn't mean that they're doing anything wrong or you as the provider are doing anything wrong. Very normal. This is generally what we see. It's kind of the most common progression if people are hitting every stage, but there is a lot of variation. The second thing to keep in mind about how we look at this is that, again, it's not flat. You see that internal spiral. The way we often describe it metaphorically is as a spiral staircase, because even though it's very common for people to pass through multiple stages multiple times, or sorry, the same stages multiple times, what they're doing is gaining experience every time that they go through that stage. So like a spiral staircase, they're moving upwards, even though they're hitting that same kind of revolution, they're turning a recognizable or a familiar corner. They're doing so armed with the knowledge of having been through that stage before, perhaps several times before. So they are a new person at that juncture and they're bringing new wisdom and new knowledge to that stage. So the pre-contemplation stage, which in that graphic we would think of as the first stage, that's where somebody may or may not recognize that there's a problem, but in any case, they haven't thought seriously about changing. The goals here are that we're trying to bring awareness of the problem up to the surface so the person can just start to think about it in a non-defensive way in a safe place. and to keep the patient engaged in the process. So this is really overwhelmingly about rapport building and enriching the relationship so that the patient stays engaged. So we're listening, we're reflecting, we're making sure that we're eliciting more information in a way that feels inviting to the patient so that they get to share about what's most important to them, and we're getting a clearer understanding about where the motivation might start to come from. And then, of course, always we're communicating caring. We're giving that unconditional positive regard, irrespective of whatever kind of behaviors they're engaging in at this point, or that they might in the future, making sure they understand that we're with them, we support them, and that they have our empathy, that we'll be authentic and accepting of them. Now, contemplation I'll highlight here because this is our link to the topic of motivational interviewing. This is that ideal stage for implementing motivational interviewing. And this is where somebody is willing to think about making a change, but they're not yet ready to do something about it. So we can think of this as sort of them straddling the fence. They have one foot in the old way, and then they're kind of peeking over to the other side and saying, that looks interesting, but I don't think I'm ready to hop over yet. So our goal here, and this is typically where we'd be using motivational interviewing, is to move the person towards action using their own goals and their own motivations. So we do that partly by keeping the person talking about change. Any kind of little comment that they make that indicates that they're mulling it over, well, it might make things easier for me, or I could see how it would be nice, dot dot dot. You really lean into that, and you're trying to ask all of the really rich questions that are going to get them to reflect, them to search more deeply about what that would look like in their life and about why that would be an appealing change for them. At the same time, we're helping them to recognize that change might be more possible than they think, because very often when people are spending a lot of time in contemplation, it reflects a lack of confidence. Very often, confidence is about them not realizing that more options are available to them than they might realize. So this could be, a lot of patients that I talk to with substance use disorders tend to have a really monolithic idea of what recovery looks like at first. They think you're using one day and sober the next, and that cold turkey is the only way to bridge that divide. So even just introducing some really basic harm reduction psychoeducation of, what would be the smallest change you could make that would be meaningful to you, and letting them know that going from, say, 1 gram a day to zero point 0.9 of a gram of a day, that would be a really important difference if that's aligned with our goals. So really just creating a lot of flexibility there, helping them move from that black and white thinking to recognizing that there are all kinds of opportunities for them to start making change towards their goal. And then at the same time, we're increasing the perceived benefit of change on their terms. We're making sure we're understanding, why is this valuable to them? Because very often it's going to be different than what we might initially think would be important for them. One way we do that is by developing discrepancy. So when we notice that they're kind of saying two different things, very often this would be something like, well, using really helps me relax. But then at another point, they'll say, it does cause a lot of conflict with my partner, my family. And then you reflect that back to them, just, non-judgmentally, you just offer it up so that they can examine those two next to each other and see, that these two don't match. And the discrepancy is where we start to be able to shape contemplation and the ambivalence within it towards some momentum for change. At the same time, we're supporting self-efficacy. Again, we're making sure the patient knows they're the captain of the ship. We're helping them to remember, what some past successes might have been, where they conquered some difficult challenge or made difficult behavior change, to help cultivate that optimism, help them stay the course. And of course, we are affirming their commitment, where we're making sure we're being that cheerleader and reinforcing them for any small step that they take towards their goal. Something that's really important to keep in mind for this stage, and this we'll talk about this in a few minutes with motivational interviewing, is that when you notice that the conversation is starting to become more of maybe an argument or a debate, that's a sign to you as the provider to take a big step back towards the pre-contemplation strategies and just focus on rapport building. If it's an obvious rupture, usually I would acknowledge it and say, hey, I'm sorry, I totally overstepped there. Let's take some time for me to make sure I fully understand where you're at, because you really don't want to push into resistance. We'll talk about that in a moment. So the next stage is preparation. So somebody in preparation stage is starting to develop a plan. They're really working on the commitment, but they haven't put it into action yet. And the developer of the model here, I think, has a useful quote to sum this up, which is, decisions do not translate automatically into action. To change a behavior, one needs to focus attention on breaking the old pattern and creating a new one, which is really a pretty complicated process. So what we as the provider do to support this is making sure that we're supporting their planning. Preparation is all about planning, is making sure that they have a clear strategy that is accessible, acceptable, and appropriate. So in other words, it's plausible for them. Part of that is making sure that they have a full idea of their repertoire of strategies. Again, this could be an opportunity if they're receptive to it, to point out some skills or strategies that they don't know about yet. And as always, supporting their commitment to change and encouraging that belief that change is possible, because this is a point where it's really easy for them to lose motivation. In the action stage, they've put that preparation and planning into action. They've made that initial attempt to change the behaviors, but very often they're not feeling confident yet about keeping this going. They're just getting their feet under them in that stage of recovery. So what we're trying to do is make sure that we encourage progress, and particularly that we help them with troubleshooting. So we're trying to smooth the path, make it as clear as possible for them to proceed with their plan for recovery. And part of that, perhaps surprisingly, is that we need to make sure that they're not biting off more than they can chew, because a lot of patients, when they hit the action stage, are so excited about it, which is just wonderful to see, that they sometimes have unrealistic ideas of what their first steps should be. So you really want to help them with scaffolding, with making sure that they get to sample success right off the bat, so that they take a bite-sized goal at first so that they can build up that momentum. The maintenance stage, this is where people have really made significant changes with that behavior. What used to be the new behavior is becoming simply the behavior. Those changes are embedded in daily life. Here, we're keeping the motivation up, because this has been a long journey at this point, and this is really action and maintenance are the key stages for relapse prevention recovery planning skills. So making sure they're invested at this point in their recovery, making sure they have all of the strategies and skills and knowledge that they need to protect that. Important part of this, of course, is a plan for re-entering the cycle of change effectively if relapse occurs, because we do know that statistically that's more likely than not for the first few stages. So that is part of why relapse, if you look back at that graphic, is built into the stages of change process. A lot of people don't quite understand that, but the developers were very passionate about this and about communicating that relapse is absolutely part of chronic illness management, any type of chronic illness. It's not a sign of failure, and that's so important for both patients and providers to understand, because otherwise we do tend to interpret it as a sign of failure if we don't understand how it fits in. It's important that we use affirming language, that we help point out that a return to use is a very rich learning opportunity. That's part of that spiral staircase that we keep moving up a flight because we're armed with better knowledge. An important point here, and this is just to sort of dip very briefly into the relapse prevention skills, is to tell them about the abstinence violation effect. And this is just a really simple verbal strategy, which is you tell them, for most people, if they've had a period of sobriety and then they return to use, they'll have the thought, you know, I really messed up. None of this was worth it. All of my work was for nothing. I might as well go back to the old way. That's the most common reaction people have in that situation. And when you can predict it ahead of time, in the safety of your office, where the patient can think it through and talk it through equanimously, then they're much more likely to recognize it when it shows up and to be able to recommit to the choice that they made, under easier circumstances, and recognize they can get right back on that road to recovery instead of reverting all the way, letting a slip turn into a full relapse. So really the ideas here are helping them to avoid becoming discouraged, and then setting them up to re-engage in the change process as effectively as possible. So we're gonna turn now to focus on motivational interviewing, and specifically the spirit of MI. So we're not, like I said, going to dive into techniques today. We're really looking at what's the big philosophy, and what can we do with that without knowing too much more. The developers have this quote, which I think sums it up nicely, which is, people are the undisputed experts on themselves. No one has been with them longer or knows them better than they know themselves. When we're talking about motivational interviewing, this is an effective method for talking with people about change. The developers really emphasize it's not talking to, and that MI is not a verb. You don't MI somebody, because that would not reflect how collaborative and person-centered motivational interviewing is. It really is a form of guiding. It's not persuading. It's not coercing. It's about eliciting and strengthening the internal motivation for change that already exists. Clinically, we're applying this when a patient might benefit from making a behavior or lifestyle change, but they're reluctant or they're ambivalent about doing so. You see how this ties into that contemplation stage of the stages of change. And usually, I think ambivalent has a little bit of a negative connotation. We like people to choose a side, especially when it affects how we work with them. With motivational interviewing, it's all about embracing ambivalence, recognizing it as an opportunity. So, of course, ambivalence is feeling two seemingly contradictory things at once. Very often, this is going to show up at a surface level as something that looks like what we want to call resistance or lacking motivation. And that's actually representing this kind of immobilization that the patient is experiencing from that internal battle of trying to figure out which side of the fence to hop over to. This is a very normal part of the change process, both before behavior change happens and then also during. And one thing that comes up a lot with ambivalence that's important for us as providers to know about is the communication trap, which is it is human nature entirely for us to see a person on the fence and us wanting to talk them into the healthy side of the fence. But that actually is going to engage their psychological reactance, which is also a part of human nature that we can't really circumvent. That's going to cause them to escalate their commitment to their existing position. So in other words, they're going to defend the status quo when we start to try to make an argument for the change. So that happens because of what's called the righting reflex. That's our very well-intended inclination to want to make it better for another person. People who get into healthcare really do want to make it better for other people, and that's a wonderful thing. The danger in it is that it often invites us to just tell the other person what to do and how to do it and why they should do it without really taking the time to talk to them and understand their own motivations and what their perspective is on it. And it really creates resistance in that we're moving away from that alongside partnering stance in motivational interviewing and into this more traditional medical model, kind of authoritative, top-down role. I know last time when we did this presentation, the participants had a great point in the discussion about how we can recognize this in our personal lives, very often in parent-child relationships or other family relationships. And I think that's a helpful way for us to start noticing how counterintuitive it is that, when we want the best for somebody, we're naturally drawn to try to tell them how and why they should do it. But that very often is going to cause them to take a step backwards towards their existing position and want to defend it. So often this comes from us thinking, they don't see, they don't know how, they don't care. We just need to, provide them with insight, knowledge, and skills. And those are really valuable assets in different stages of change, right? So in planning, skills are so important. Similar in action, maintenance, insight, and knowledge is indispensable. But for contemplation specifically, where we're using motivational interviewing, we're not trying to add things to the conversation generally. We're trying to elicit what the patient is already knowing and thinking about. Some of the consequences of the writing reflex are, they'll briefly make a change to make us happy if they like us, but recovery is a really long and rocky road, and they need to be sustained by their own internal motivation or it won't stick. They might listen politely, go ahead and do whatever they were going to do. They might protest, and that's going to cause us to push harder. In any case, no one benefits, and we often blame the patient, right? We say they're not motivated or they're resistant, when the reality is we fell into that communication trap, we succumb to the writing reflex. And I think this visual helps us to recognize when we indulge in that writing reflex, we're really just locking horns. We're almost strengthening the muscle, in a sense, of the patient's commitment to the status quo. So we're accomplishing the opposite of what we want to. Part of how we can avoid this is remembering the rule of MI. Motivational interviewing loves their acronyms. R is simply resisting the writing reflex. That's knowing that it happens, recognizing when it comes up. Like I said, it can be helpful to do this just in everyday life. And then going to the other side behaviorally by understanding your patient's motivations, listening to them, empowering them. That's kind of the opposite of the writing reflex, is really, sitting back in your chair and acknowledging that they're the expert and eliciting their expertise. An important point here is, like I said, skills and techniques, true, MI training to fidelity takes a long time. There's a lot of art and science, but the developers really emphasize that the spirit is the most foundational piece, and that even if you're incredibly skilled and you know all of the bag of tricks, if you're not really incorporating the spirit of MI that we're talking about, then you're not actually doing motivational interviewing, and it's not going to work. So there's a lot that you can do just with the spirit, just with recognizing these principles, even if you are not able to get the training and learn more about the skills and techniques. So when we talk about the spirit, this is yet another one of those acronyms: ACE, acceptance, collaboration, evocation. When we talk about acceptance, this is really as a counterpoint to authority. So this is about accepting people just as they are, totally independent of whatever behaviors they're engaging in. This is that unconditional positive regard that there's just this fascinating thing called the Rogerian paradox, which is when people are accepted for exactly how they are, they're much more likely to actually make change than if they feel that they're being judged or they feel that they're trying to be persuaded into a new approach. So it really is this paradox of if we can take them just as they are, then they're likely to become a new person through that process. We do that through striving for accurate empathy. Nobody's ever 100% accurately empathic, but we're trying as hard as we can to really understand things through their eyes, especially the meanings and the values related to their change goals. Again, as I've said before, it's so important to support their autonomy, acknowledging they're the captain, they have the freedom to make this choice, and really affirming, every small incremental step that they take towards their health goal. We want to reflect, you showed up today. That's a really big deal. We really communicate appreciation for what they've done now as well as in the past in terms of cultivating that motivation based on previous successes. Collaboration is a counterpoint to confrontation. So again, the dynamic here is really it's dancing rather than wrestling. This is the phrase coming alongside is used very frequently. And we want to remember this is about exploration rather than persuading. It's really hard to let go of that attachment to the outcome, but when we can and we can genuinely just bring that gentle curiosity rather than our sort of internal, debate team lead to the fore, it's just so much more effective in allowing change to happen. So again, just returning to that point that patients are the expert on themselves, and we want to put them in the driver's seat to make these changes for that reason. The E is evocation versus education. So this is about bringing out what's already inside rather than us putting something, onto or into the patient's, their brains, their behaviors. So the message is you have what you need. Together, we are going to bring it forth. We'll elicit and evoke it. So it's about drawing on what the patients already have and strengthening the motivations that are there, helping to educe, what is their why? Why is this important? In a true, vivid way, what are they envisioning the other side of this decision to be like? So this is very much, again, rooted in the patient's perspective and their own wisdom. I know we're right about time for the presentation, so I just want to mention culturally adapted MI, CAMI. It's really exciting. In the past few years, there's been a lot more research about how we can make motivational interviewing more multiculturally responsive. It's a great candidate for it because it's so person-centered. So I just want to point you in the direction of this research if you're interested. That is an attempt to kind of structure how can we ensure that we're conducting MI in the most culturally responsive way possible. And then lastly, a slide for your reference, really, because the literature on motivational interviewing is incredibly robust. A couple points that I'll just highlight here that I think are really interesting is that some of the earlier pilot studies in the earlier 2000s showed that the outcomes were better when no manual was used, which seems confusing, but what it turns out is that that was an iteration that was much more similar to cognitive behavioral therapy. So there was a mandatory change plan at the end of each session, which we know now with a fuller understanding of motivational interviewing is totally antithetical to its spirit. So the clinicians who were just going with the philosophy and they didn't push the change plan, of course, they had better outcomes because that was actually higher fidelity MI. So I think just a great representation of how important the spirit is. And then also in more recent meta-analyses, just showing that it's useful in as few as a single session, sometimes a relatively brief session. So obviously very useful for, a variety of medical settings. And also that effect sizes were largest for outcomes that related to weight loss, blood pressure, and substance use, which you all as providers can appreciate are particularly intransigent categories of behavior. So it really shows how potent MI can be. So I'll just leave you with some resources. These cover both training sessions and materials. The first couple are links to calendars of local organizations that often provide free training or low-cost training. I'll say thanks to our SOAR grant, which we're operating under as well. One of these local organizations very, very frequently offers free training. So keep an eye on those. And then there's an instrument that CASA came up with called Socrates, which helps us if we want a formal instrument to assess stages of change. And I'll switch now to questions.